In the 1950s, West Germany rebuilt fast, but people carried heavy strain. Long work days, tight housing, and fresh memories of war pushed many toward quick relief. Doctors and pharmacies faced constant requests for something to calm nerves and bring sleep. For drug companies, that demand looked like a doorway to the future. They needed products that sounded modern, scientific, and safer than the older sedatives that scared patients and regulators. Inside this competition, chemists searched for new compounds that promised steadier calm without obvious danger. One of those compounds became thalidomide. It emerged from routine laboratory work and early checks that looked reassuring. Test animals did not drop dead. Obvious poisoning did not appear. The basic signs that usually stopped a drug early were missing, and that absence mattered. In a market hungry for simple answers, no clear harm quickly started to sound like safe. That early impression fed confidence inside the companies developing it. If a pill seemed gentle in the lab, it could move quickly toward bottles, brand names, and sales teams. West Germany's pharmaceutical industry wanted to prove it belonged among the world's leaders again, and a successful sedative could do that. Thalidomide looked like the kind of product that could spread fast, easy to take, easy to promote, and, at first glance, almost too harmless to question. Once thalidomide reached the market, it arrived with a clear promise: calm, sleep, and no addiction. It was presented as a modern answer to everyday nerves and nighttime restlessness. The most powerful claim was also the simplest. It was said to be so safe it could not cause a fatal overdose. That message removed fear. It made the drug feel less like a risk and more like a relief. That promise changed how quickly it spread. Doctors had long worried about dependence and dangerous dosing with older sedatives, so a drug labeled non-addictive sounded like progress. Prescribing became easier, caution softened. Pharmacies stocked it widely, and the public learned the name fast. It became something people asked for, not something they hesitated to take. Safety, repeated often enough, turned into certainty. In a short time, thalidomide moved from new product to routine medicine. It sat among trusted remedies, used for ordinary sleepless nights and anxious days. The marketing did not just sell a pill, it sold reassurance. And once that reassurance took hold, the drug's reach expanded on its own. More prescriptions meant more exposure across more households, with fewer questions. The trust came first, the consequences followed later. Thalidomide no longer stayed in the narrow category of a sleep aid. Its makers pushed it outward, into the messy world of everyday discomfort. It was presented as something that calmed nerves, settled the stomach, and took the edge off ordinary life. That shift mattered. A drug taken at night by a smaller group now entered daytime routines, carried in handbags, recommended for minor complaints, and used more often. One complaint stood out: nausea, especially the nausea of early pregnancy. Morning sickness was common, exhausting, and hard to treat, and many women wanted help that did not feel risky. Thalidomide was positioned as exactly that kind of answer, gentle, modern, and medically responsible. Doctors and pharmacists treated it like a safe choice, and the message filtered quickly through families. A reassuring label became a powerful invitation. Soon, pregnant women took thalidomide at scale, often in the first weeks when pregnancy might not even have been publicly announced. The drug's reputation did the work. If it was sold openly and recommended without alarm, it felt endorsed by medicine itself. The more ordinary the use became, the less anyone questioned it. In a short time, thalidomide moved from a sleeping pill to a routine remedy for pregnancy nausea, and it did so with trust as its engine. By the late 1950s, the first troubling reports arrived, not from a lab, but from ordinary patients. People who had taken thalidomide for weeks or months began to describe strange sensations: tingling, numbness, burning pain in hands and feet. Some lost strength. Doctors recognized the pattern as peripheral neuropathy, damage to nerves that usually had a clear cause. Here, the cause stayed uncertain, but the timing kept pointing back to the same pill. These were not dramatic, immediate reactions. They crept in slowly, which made them easier to doubt and easier to dismiss as stress, age, or unrelated illness. The warnings that did surface stayed scattered: notes in medical letters, cautious comments at meetings, isolated case reports. Some physicians stopped prescribing, others never heard and shrugged it off. The drug's reputation for safety stayed louder than the early evidence against it. Manufacturers and promoters leaned on a simple idea. The benefits looked obvious and the harm looked rare and unproven. Without a strong system to collect and forcefully act on side effect reports, concern turned into background noise. Packaging and advertising still pushed reassurance. Pharmacies still stocked it. So even as credible harm signals accumulated, nerve problems, other unexplained complaints, the medicine continued moving through clinics and households, treated as dependable and routine. Around 1959, something began to unsettle maternity wards and pediatric clinics. Doctors started seeing newborns with limb malformations so rare that many clinicians had only read about them. Arms ended in small, hand-like stumps. Legs failed to form normally. These were not isolated tragedies. Case after case appeared, and the timing felt wrong. Too many, too close together, in places that had not seen patterns like this before. As months passed into 1960 and 1961, the numbers climbed. Hospitals that handled thousands of births each year noticed the change in their own records, not in distant reports. The defects varied: missing thumbs, shortened forearms, deformed ears, heart and organ problems, but they clustered in a way that suggested a shared cause. When clinicians compared notes across regions, the same frightening impression formed: an epidemic had emerged. The most disturbing detail involved geography. The surge appeared in multiple areas where thalidomide had spread into everyday use, including among pregnant women. Midwives and doctors began to recognize that these babies came from ordinary pregnancies that seemed normal until birth. Nothing about the deliveries explained what happened, yet the pattern kept repeating, and each new case added weight to a growing suspicion that something used widely and recently had changed the fate of these pregnancies. As the number of babies born with severe limb defects climbed, a few doctors stopped accepting it as bad luck. In Germany, Widukind Lenz compared case after case and noticed a disturbing common point. Many mothers reported taking thalidomide early in pregnancy. The dates mattered. When he lined up the week the drug was taken against the stage of fetal development, the pattern tightened into something that looked less like coincidence and more like cause. Lenz pushed beyond suspicion and began collecting evidence fast. He tracked prescriptions, interviewed families, and mapped the narrow window when exposure seemed to produce the worst damage. At the same time in Australia, William McBride, an obstetrician, saw similar defects and followed the same trail back to thalidomide. Two clinicians, worlds apart, reached the same conclusion from their own patients. That kind of overlap carried weight. Their warnings did not stay inside hospitals. Both men pressed authorities and medical journals, arguing that thalidomide taken in early pregnancy triggered these malformations. The claim sounded explosive because it challenged the drug's image of safety. But the reports kept accumulating and the timeline kept matching. Each new case strengthened the argument. The question shifted from whether something was happening to whether officials would act before more pregnancies reached that critical window. By late 1961, the pressure finally broke through. Thalidomide disappeared from pharmacy shelves in country after country as regulators and manufacturers moved to stop sales. But withdrawal did not end the damage. It marked the moment the consequences began to surface in full. Families who had been isolated suddenly realized they were not alone. The same rare, devastating defects kept appearing, and the dates lined up. A medical warning became a public emergency. As reports piled up, the numbers stopped sounding like scattered tragedies and started sounding like a count. Hospitals compared notes. Health ministries began collecting cases. Newspapers printed photographs and summaries that were impossible to ignore. Thousands of parents came forward, asking the same questions and receiving the same terrible answer. What looked unthinkable in one town looked undeniable across borders. The story no longer belonged to doctors and journals. It belonged to the world, and it carried names, dates, and totals. Now the crisis turned into scandal. Headlines spread from Europe to other markets that had sold the drug under different brand names, forcing companies and governments to respond in public. Victim counts were documented, revised, and reported again, each update expanding the scale of what had happened. Behind every statistic stood a child who would need lifelong care and a family trying to make sense of it. The withdrawal came too late for them. The damage had already been written into a generation. After the withdrawals, governments faced a hard fact. The system had allowed a drug to reach pregnant women without proving it was safe for unborn babies. That failure demanded new rules. Regulators began requiring deeper preclinical testing, including studies that looked for harm to embryos and fetal development. It was no longer enough for a pill to seem harmless in adults. Safety had to include pregnancy before a product ever reached pharmacies. The next change targeted how drugs were tested in people. Companies had relied on loose, uncontrolled use that looked like everyday prescribing, and dangers blended into the background. New expectations pushed trials to become controlled and structured, with clearer records, defined groups, and careful follow-up. Evidence had to be gathered on purpose, not discovered by accident. Side effects, especially rare ones, demanded systematic tracking. The burden began shifting onto manufacturers to prove both safety and real benefit. In the United States, that shift hardened into law through the 1962 Kefauver-Harris amendments. Drug makers now had to show proof of effectiveness, not just claim it, and they faced stricter oversight of trials and reporting. Approval standards tightened, and regulators gained more authority before a medication could be marketed widely. Thalidomide did not just end a product's life. It rewired the rules of modern drug regulation, turning a catastrophe into a permanent checkpoint. The babies who survived did not simply grow out of the damage. They entered childhood with missing or shortened limbs, hearing and vision problems, and internal complications that only became clearer over time. Ordinary tasks demanded constant adaptation. Surgeries followed, then more surgeries. As they grew older, many faced chronic pain, joint strain, and exhaustion from bodies forced to work in unnatural ways. Their families also faced a different struggle, being believed and being helped. Support depended on paperwork, medical boards, and companies that moved slowly or resisted responsibility. Compensation programs appeared, but they often felt like negotiation instead of care. Survivors organized, pushed for recognition, and demanded long-term services, not one-time payments. For many, the fight lasted decades and followed them into adulthood. Inside medicine, thalidomide forced a hard question. How did a drug reach pregnant patients without proof it was safe for unborn life? Researchers mapped the narrow window in early pregnancy when development was most vulnerable, and they studied how the drug disrupted growth in the embryo. That science carried an ethical warning too. Thalidomide stopped being just a tragedy. It became a permanent symbol of accountability and a rallying point for patient activism. Decades later, thalidomide still remained in medicine, but it never returned as an everyday sedative. Doctors used it for narrow, serious conditions, including some cancers and painful complications of leprosy. That survival came with a price. Thalidomide became a drug handled like a controlled hazard, not a comfort. It stayed available only when the benefit looked clear and the risks could be managed. Access no longer meant a simple prescription. Patients entered strict pregnancy prevention programs with regular testing, written warnings, and tight rules for dispensing and refills. Clinics tracked use. Pharmacies followed special procedures, and every step tried to stop fetal exposure before it could happen. The point was blunt. One missed safeguard could mean irreversible harm. Thalidomide became a lesson built into the routine of care. That contrast carried the real legacy. In the 1950s, thalidomide had been treated as casually safe, even gentle enough for pregnancy nausea. Now, it stood as a permanent caution. Pregnancy could not be an afterthought in drug development. Safety testing had to ask harder questions earlier, and regulators demanded proof, not reassurance. Thalidomide did not just change one drug's rules, it changed the world's standards.